Today is close to Christmas, and we've decided that after witnessing the silly sweaters in our sister podcast that were smashing sweaters and a fantastic podcast with Ellie and Alex, we decided to put the podcast in a Christmas spirit too, since this is the last podcast of the year. And we've decided to wear hats. And as you would see, my guest is an expert and a master of the hats. So he actually borrowed this hat from him, and he's also wearing a really interesting hat. So you're listening to this podcast, I recommend you to go to your video and see how interesting these hats look. So welcome to Editors in Conversation. So we're going to talk about COVID-19 for this last podcast, which actually we haven't talked about COVID-19 the entire year on purpose because we wanted to just pay attention to other things going on that are important. But I think it is fair to say that it's important to revitalize our COVID-19 knowledge. And COVID-19 continues to pose major problems in the winter here in the United States. There are data that suggest infection and hospitalizations are still increasing with a surge. And there is also a fear of emergence of new variants for things that happen in different parts of the world. But also the therapeutic tools and new data are available. So we would like to discuss this in more detail and all these developments in this podcast of the end of the year. And happy Christmas, happy holidays, and happy New Year to everybody. So the objectives of today is to discuss the latest facts on COVID-19, comment on current therapeutic approaches, including antivirals and monoclonal antibodies, and provide a futuristic perspective of the coming year on COVID-19, with the caveat that we all fail about projections of what's going to happen. This episode of the podcast is brought to you by Antimicrobial Agents and Chemotherapy, available at aac.asm.org. I am your host, Cesar Arias, Editor-in-Chief of AAC, and this podcast is supported by the American Society for Microbiology, which publishes AAC. If you plan to publish in AAC, ASM members get up to 50% on publishing fees discount. So become a member. Visit the asm.org/membership website to sign up. And don't forget to check our latest issue of AAC. It's the leading journal on antimicrobial agents and resistance, available at aac.asm.org with outstanding papers on mechanism of resistance, pharmacology of antimicrobial agents, epidemiology, and clinical therapeutics, among others. So joining me to discuss the COVID-19 situation is Dr. Adarsh Bhimraj, who has already been in the program before in the show. So welcome back, Adarsh. He is an infectious disease physician and serves now as Director of Education and Fellowships in the Division of Infectious Diseases at Houston Methodist Hospital. But he also serves, has been for almost more than 2 years now, chair of the IDSA guidelines for COVID-19. Welcome to the program, Adarsh.
Yeah. Thank you, Cesar. Thank you for having me. And I love your Santa hat, and I'd love to play Elf in this video chat.
And this is, I remember your hats in Bug Bowl and others, and they've been a sensation. So I thought that we should be festive now that we are closing this year and looking forward with more optimism next year. So, Adarsh, where are we on COVID-19? What can you tell us? What's going on? What are the current concerns and what's happening with these new variants?
Absolutely, Cesar. I think I'm going to put on the lens of treatment rather than vaccines or anything else. But I never ever thought 3 years ago that I'll be standing here today and talking about COVID-19. When the pandemic all started, and I think we all thought this will be over, maybe max in a year, but here we are, we're still standing. So it's a humbling experience. And I think not just this pandemic, any pandemic, I think we should be open to uncertainties. So COVID-19 is still here. It is not gone. But the good news is, I think when you look at the current variants, and we'll get into a little bit, I think the severity of the disease is not as bad as what it used to be, at least early on in the pandemic. So, and if you look at the news, in addition to COVID-19, during this time, we're also finding a slight rise in influenza as well as RSV. And we do see an uptick in cases and also some hospitalizations and death. And we also see that the lineages, mostly the Omicron lineages, predominantly that is BQ1.1, BQ1, BA5, and XBB. Later, when we come and talk about monoclonal antiviral therapies, we'll realize that uh, so as these variants keep changing, we have to be mindful of the implications of at least in vitro susceptibilities and clinical responses of the treatment. But I don't want people to lose hope. And I think we are in a different situation. I think we're dealing with a milder form of disease than in the past. Surprisingly, a lot of the people, again, are still not vaccinated, but at least when you look at people who are vaccinated or those with maybe even because of prior infections immunity, I think the severity of the disease is much less. And also, we have a lot more treatment options today than we had, let alone 3 years ago, even about a year ago.
So, Adarsh, thank you for that. So, I want to go back to that point of severity of disease. I mean, we clearly are seeing a kind of a different pattern, but there's patients that continue to have problems with the immune system, mainly all these immunocompromised patients, for different reasons, continue to be a higher risk for this disease, clearly show. But what do you think is this sort of presentation of sort of kind of milder, more manageable? One hypothesis, of course, is that we've been through so many waves with people having one or more, and there is some sort of degree of herd immunity, even though there is not the enough people vaccinated as we would like to have on this. But between vaccination and natural infections, particularly these new variants that are mostly Omicron variant lineages. So there are some certain immunity. However, again, the most vulnerable, older, and immunocompromised patients continue to be a high risk. What do you think about that?
No, I think, Cesar, I want to be cautious. Whatever we do is speculative at this point of time, right? Again, like, people, one thing I want, like, again, the severity of the disease is less, maybe because in most people, either because of prior infections or vaccinations, there's some immunity. But I don't think it is complete immunity because you're still seeing people who are getting sick. And I also want to look at, when we look at outcomes, we just think, okay, how many infections are there? But maybe the vaccinations and prior immunity may not completely protect you from the new variants. But if you look at consequences, by which I mean, are you progressing to have severe disease or critical disease that you're getting admitted to a hospital or the ICU? Or are you having deaths? We are seeing much less of that now than in the past. So even though the vaccines may not be fully efficacious in preventing infection from the new strains, I think there's enough data to show that it does prevent severe outcomes. Now, we do have the immunocompromised population. And again, and I think I wish there's more research in terms of like passive immunotherapies as well as treatments, because the burden of disease is still predominantly in that population. Another thing is that if you go back and look at studies in Omicron, even if you go back and look at the trials, one of the biggest risk factors is still age, right? So again, if you take age above 65 and especially age about 80, I think for every 5 years increase in age, again, is it immunosenescence? And again, I'm speculating at this point of age. Are there anything we can do better, even in terms of vaccine efficacies? Are there other things in this older population, not just immunocompromised? If you think about age, I think not only is it the strongest risk factor, it's the biggest risk factor, which is making people more prone for COVID-19 and also consequences of COVID-19, hospitalizations, and other things.
Yeah, absolutely. I think that's a very important point. Another comment that I would like to make, and I would love your thoughts about, is what is currently happening, for example, in China, where the policy of relaxing that zero COVID policy may spur the emergence of new variants. Are you worried about that? So, how worried should we be?
Probabilistically, Cesar, that is there, right? China is still the largest country. And again, so if there are more circulating virus, and I think the probability there'll be new variants that will be there. But look at the rest of the world. We have variants coming up and lineages and subvariants. And most of the time, at least post Delta, the severity of the infections have been coming down. So hopefully, again, it doesn't go backwards. Hopefully, we are not going to get another variant where the severity of the disease is like worse off that we can't deal with it. I'm hoping that is not the case. Maybe I'm naive and maybe I'm being optimistic. Uh, but I'm also humble enough to know with COVID-19, anything is possible, as we have seen in the past. Yeah, I don't think we have a choice whether there will be new variants emerging. I think there will. The question is, will the variants be causing more severe disease in this population right now? And I'm hoping we don't see that happening in China and again, spreading to the rest of the world.
Yeah, I share your optimism and hope as well, particularly now in these festive times. But of course, people are gathering indoors, families are getting together, and it is likely that it's going to spur new surges in January. So, crossing our fingers that it does not become unmanageable, and we can pull through. So let's talk about now. So antivirals. Basically we have three drugs there: the maltravir, ritonavir, also called Paxlovid, the molnupiravir, and remdesivir. So you've examined the data of all these antivirals. What are the current recommendations and guidelines to use of these antivirals? And is there anything new regarding these agents?
Yeah, no, that's a great question, Cesar. Again, there's some new antivirals too, and often I think the way I approach antivirals, like the larger question is, if I have a patient with mild to moderate infection with COVID-19, what do I do? That's where the antivirals come in mostly. And I also want to say, if you look at it, if you're mild to moderate disease and if you don't have risk factors of progression, most of the data shows that antivirals might not benefit that much. I think so. It is those patients who have a higher risk of progression. So, like you said, the landmark trial that led to authorization of nirmatrelvir ritonavir was the EPIC HR trial. And then for remdesivir, it is on the outpatient side, it is the Pine Tree trial. And molnupiravir, the effect size, again, for remdesivir and as well as nirmatrelvir, I think it was almost like a 70 to 80% relative risk reduction that you've seen with hospitalizations. But with molnupiravir, it's about 30%. But none, and that study is called the Move Out study. All these studies were done in predominantly patients who were not vaccinated, or the vaccination rates were extremely low. And if you look at the predominant variants also were Delta variants, or we are talking about pre-Delta most of the time. And event rates, like the rate of progression to hospitalizations or anything else, was much higher in this trial. So one of the questions that kind of lingered is in this phase of the pandemic, where you have Omicron and Omicron sublineages, which are predominantly there throughout the world, and most of the population is vaccinated, do you think these antivirals are still effective? And to answer that question, I think there have been two large real world studies, one out of Israel, which looked at data in a health system, a large health system, and looked at nirmatrelvir ritonavir, which is Paxlovid. Paxlovid, even where the predominant variant was Omicron and most patients were vaccinated, and mind you, in Israel, it's the mRNA vaccines that they got, above the age of 65, it still showed a mortality benefit and it decreased the rate of hospitalizations. So clearly, I think in high-risk patients and in elderly patients, which is one of the highest risk, even with in an Omicron era with vaccinations, it's effective. And similarly, there was a large study that was published in the Lancet, which looked at Hong Kong. In Hong Kong, real world data during Omicron and vaccinations, they looked at both Paxlovid, nirmatrelvir, ritonavir, molnupiravir, and they compared it to no antiviral agent. And they both were beneficial in reducing outcomes, including mortality. So in the high-risk patients, at least these two agents, I think there is data. Now, the issue comes with molnupiravir, right? There's a lot of controversy with molnupiravir because its effect size was much less compared to remdesivir or like nirmatrelvir, ritonavir. And the second issue was there were these issues about mutagenesis. Two things. Again, does it have any reproductive concerns if somebody wants to have a baby, both from the male partner as well as the female partner? And also mutagenesis within the virus, especially in immunocompromised host, because it causes these multiple mutations, can it mutate into a more virulent form or a more resistant form? So safety concerns were an issue when we first looked at the Move Out trial. But if you look at both, especially the Hong Kong trial, I think the safety effects of molnupiravir was fairly well. I know it's an observational study, but nonetheless it did. Another large trial, I think there was a huge randomized control trial, the principal trial, which looked at molnupiravir. Unfortunately, in terms of hospitalizations and death, it did not show a huge effect. But then the baseline rates with the new variants and with vaccinations was so low in the placebo arm. I don't think any other agent in this phase of the pandemic will be able to show reductions in hospitalizations or mortality at this stage with the phasmic. And that was not, I think, the right outcome to look. But it did reduce the durations, again, basically of symptoms. Unfortunately, this was an open label study. So you could say that it could be the placebo effect that could have. Like, again, looking at the totality data, Cesar, I think molnupiravir may not be as effective as remdesivir or nirmatrelvir, ritonavir, but there are a subset of patients who cannot receive nirmatrelvir, ritonavir. I think it's almost 10 to 15% of the patients with drug interactions, with severe drug interactions. In those patients, I think molnupiravir is an important alternative. I think the safety concerns have largely been alleviated with these large trials as well as observational data. You can use remdesivir, but the trouble with remdesivir is all the antivirals work best when you give early. Ideally, if you look at these study designs, it has to be either 5 days. For remdesivir, it's 7 days. The logistics of giving remdesivir once a day as an outpatient, especially dragging somebody who's COVID positive into an infusion center, are not there. So I think people should be using uh, like the oral antivirals early on in high risk patients. And theoretically, also, you'll reduce transmission because there's decreased viral loads, which have been shown in it.
Very
And for,
important. So sorry to
yeah,
interrupt here, Darsh. I just want to go back to the drug interaction with nirmatrelvir, ritonavir, because I think there was a lot of concern about, particularly in the older age, with patients taking cardiovascular medicine. I think people are becoming much more comfortable with those interactions. Can you talk a little bit about that, for example, and with cardiovascular drugs or statins, etc., and of course some of the antiplatelet agents?
yeah, yeah, absolutely, Cesar. I think there's a lot of fear. I've seen a lot of patients where the providers, and again, most of the time they don't come to you, they go to a primary care physician, they go to an ER, they go to an urgent care. They'll look at the medication list and they say, oops, you have drug interactions, we can't prescribe you. But the reality is, there's a small list of drugs where you can't do that. But a lot of the other drugs, either you can hold the drug or either you can monitor the drug closely, and that should be okay. I'm going to use my own example. I guess I'm being transparent. I am on a lot of cardiovascular drugs, including antiplatelet agents as well as statins. And I ended up having COVID-19, and I do have risk factors. So the initial was, oh, we can't use Paxlovid. But the closer I discussed it, again, I was able to hold my statin again for 10 days. And given where I am, I think I continued my antiplatelet agents. But so there are ways. And what I recommend is, so far, the best thing and the easiest thing to do for an outpatient is treat patients early with nematomia ritonavir. I don't have any stock on it. You have a great app, I think the Liverpool app and the website, where any provider within 5 minutes can check drug interactions. What I recommend, if somebody reaches out to you, again, majority of the time, these are not insurmountable barriers. The drug interactions are manageable. I think that's the first step before you even consider any alternatives people should be doing. And again, it's anecdotal, but I significantly felt better after taking the Paxlovid, and I'm glad, like with my providers, I was able to initiate it in a timely manner.
Yeah, fantastic advice. Thank you very much for that, and your own example. That's really great. Okay, let's move on to monoclonal antibodies. A lot of hype at the beginning, a lot of antibodies available. As the virus evolved, we're sort of losing more and more and more, including those that were used for prevention. So where are we with these new variants and the monoclonal antibodies?
Yeah. Now, again, Cesar, one of my favorite quotes, I've used it multiple times, as Heraclitus, the Greek philosopher, said, "The river you see into is not the same river the minute you step into it." Nothing is more true than monoclonal antibodies, because by the time the randomized clinical trials are published on one variant, then a new variant comes and those things are not available. Let's go back to the last time there was at least one FDA approved EUA, was bebtelovimab. Even the data on bebtelovimab was based from a phase 2 study. We really didn't have any huge clinical efficacy studies, but we still had one because the other agents showed decrease in vitro susceptibilities. But now, as you know, as in November 30th, FDA revoked the only authorization, the only monoclonal antibody, neutralizing antibody, bebtelovimab for treatment that was there. So if you look at in vitro susceptibility data, and again, that's the best data we will get. Unfortunately, you won't find clinical trials. I think for BQ 1.1 and BQ1, and also to an extent XBB, it's almost 1,000-fold reduction in susceptibility. And there's no practical reason this should work, and we don't have any other options uh, in terms of treatment. And what is a little more interesting is for prophylaxis. Now, for treatment, let's say we don't have bebtelovimab, you still have options, correct? We have, again, the antivirals, remdesivir. Again, we have molnupiravir as well as remdesivir. But for prophylaxis, if somebody has a severe adverse reaction to a vaccine or is a vaccine non-responder, like they're immunosuppressed, again, your only response, at least, is either you use a monoclonal antibody, or highly controversial is like if we can find the right kind of convalescent plasma. So, and if you look at in vitro susceptibilities, I think it's to the fold of almost 400 and 700 times decreased susceptibility to tixagevimab, selagevimab. Interestingly, everybody's silent on this. There are some institutions which have stopped using it as for prophylaxis, but my recollection is the other institutions, especially in immunocompromised cells, they're still using it. And most of the guidelines and FDA have also been silent about it, because if that's not an option, what is the option? But there are some papers which actually show that I think there's some cardiovascular and fluid overload, the other effects that may be deleterious for monoclonal antibodies, especially tixagevimab, selagevimab.
And we don't have options, right? We don't have really new options.
We don't have options. But my fear, and again, that's my own opinion, Cesar, is like you have high in vitro, again, reduction in susceptibilities, but you do have some adverse effects and also logistics of administering these things. I think that has to be taken into consideration. I don't know what the jury is, but I don't think, like, at least in the past, if you have a highly susceptible variant, I think there was a balance.
Not to mention the price.
And risks. Yeah. Again, and so I hate to say, but I guess unless there's a new variant, and that can happen, it goes back to being susceptible, or unless there's a new mAb on the block, which is better, I think the mAbs are pretty much retired for now.
Yeah, that's a very clear perspective on this. Okay, so let's move on now on therapies that you use for sicker patients. We touched about antivirals that, as you mentioned, you wanted to give it early in patients at high risk, even as preventive to prevent progression, the monoclonals and all that we just mentioned. But now there seems to be now a lot of even recent data supporting the use of anti-inflammatories, particularly IL-6 inhibitor like tocilizumab, in patients that are critically ill and eventually end up in the ICU. What can you tell us about those approaches?
Yeah, absolutely, Cesar. I think I'm going to jump on and go to the past and build the context a little. If you look at one of the most landmark trials was recovery for dexamethasone, right? And I think there is implications beyond just COVID-19. The idea that in a critically ill or severely ill patient, the fact that the immune system can cause damage and you can use immunomodulatory drugs. So, so then what after dexamethasone? Again, you already have dexamethasone, which showed a significant reduction in mortality. Are there roles for other immunomodulatory? In that realm, two things that came up was the first thing was IL-6 inhibitors, tocilizumab, and then sarilumab. And then following that was baricitinib, right? So, and again, more than tofacitinib or anything else. So one is a JAK inhibitor, the other one is a IL-6 inhibitors. Both actually showed a survival benefit in the trials. So, and the question is, like all these trials, most of the patients kind of received steroids. They had either baricitinib or tocilizumab. They haven't really looked at, okay, can you use any other agents? Can you use the combination of agents? Or when do you actually add these agents? They didn't really provide any clarity on that. And also, what are the long-term consequences? So especially for IL-6 inhibitors, one of the big concern was like, okay, will you be more prone for TB or other opportunistic infections? So two landmark trials that studied IL-6 were REMAP-CAP and recovery. So REMAP-CAP, when they first published their results, I think it was a 28-day mortality, 28-day outcomes. So very recently, what was published in JAMA is they went ahead and looked at outcomes at 120 days. And which is interesting is they didn't look at, okay, what is the long-term mortality at that endpoint? They looked at quality of life and disability. I can't emphasize the importance of that. Like, okay, somebody survives, but if they're so disabled, if they're ventilator dependent, is it really meaningful survival? So I think that was a very important outcome because of the nature of platform trials. They were able to go ahead, continual platform trials, study it. So the IL-6 inhibitors actually still showed a survival benefit. And surprisingly, a lot of the opportunistic infections and whatever thing we thought we will be finding later on at 120 days was not there in REMAP CAP, that particular trial. I guess I can mention over here is they looked at multiple other agents too. So they looked at surprisingly antiplatelet agents, aspirin and P2Y12 inhibitors like clopidogrel. Even though they did not show a 28-day survival or mortality benefit, at 120 days, interestingly, they showed that. So it's not only that, I think they also showed improvements in disability as well as quality of life. The caveat I'm going to say is this: there's a lot of missing data when it comes to quality of life and disability, but I think mortality itself, despite all that, you can take. So there's something about antiplatelet agents, I guess, stands to reason because if you remember early on, one of the pathogenetic features was microthrombi within the like circulature within the lungs. So maybe it does play a role, but I think that still needs to be evaluated in a trial because there are earlier studies which showed these agents can also increase bleeding risk. So I think it's hypothesis generating, but not hypothesis proving. But certainly it stands to pathophysiological. So that is the IL-6 inhibitors and the platelet agents in REMAP CAP. Um,
But
the
it doesn't. Don't you believe? Just to interrupt, because this is a very interesting point that you're making. I think probably the IL-6 inhibitors are probably now considered really standard of care in that population. However, I think the antiplatelet agents, I would not consider them standard of care just yet because the level of evidence is not that strong. Would you agree with that?
And absolutely, as I said, I think there are more trials that are needed, Cesar, with antiplatelets. But IL-6, yes. And again, the same thing with baricitinib too. But one of the troubles with these trials, Cesar, again, if somebody's critically ill in the ICU, or if somebody's on high flow, you can use them. But is there a critical window where you can start these agents early on that you even prevent progression? Because these trials, if you look at it, haven't answered the question like, what is the right candidate before they get really, really sick, where you have started remdesivir and dexamethasone. Hey, and these guys are getting worse. When do you start baricitinib? When do you start IL-6 inhibitors? So we know they're useful, but when to exactly start, I guess it's more an art at this point in time rather than something that the evidence clearly tells when to use them.
And the experience told that probably the earlier that you can identify that patient, probably the better will fare you use those agents. And that was something that you would probably learn at the beginning of the pandemic when we were using this and got used to these patients that had this inflammatory response that were really heightened. So
And yeah,
go ahead,
and again,
please.
and that's the thing with baricitinib. If you look at the trial, high flow is the population that benefits, but not once you go to ECMO or mechanical ventilation. So that's sticking to the same question. There are some new agents I do want to mention. So Active One actually went in and looked at one infliximab. Again, and the other agent which looked at, it's not just a TNF alpha emitter, it's abiracept. Right? Again, both these agents showed a significant decrease in mortality in severe, disease. The primary endpoint was actually symptom duration. It didn't make a big difference, but it did show a mortality benefit. These are the two agents. Surprisingly, I was thinking there'll be an EUA something for these two agents, but we haven't seen that. What we do have an EUA for most recently is an IL-1 inhibitor, which is anakinra. There have been several studies. In fact, the main study that led to the EUA is called SAVE-MORE study, which was actually published in October. It's been a long time ago. But if you go back and look at the study, it is the WHO progression on, the progression on a composite endpoint is what it showed a benefit. It didn't really show, again, depending on how you look at the analysis, such a meaningful reduction in progression to mechanical ventilation and survival. So IL-1 and anakinra now as a EUA, but surprisingly, I thought data is much more stronger on, TNF alpha inhibitors and abiracept, which, again, there's not much enthusiasm or not much even a EUA for that.
Yeah, it's very interesting how this pandemic is sort of teaching us that we get into this modulation of the immune system that is so complex that people are very hesitant. When you block one pathway, what happens with the other pathways and all that. But I think there is a lot of research and a lot of new findings that now is being open to try to dig deep into these pathways of as anti-inflammatory strategies for patients with this disease and others that in which the hallmark is just systemic inflammation.
Yeah.
So we're in December 2022, Adarsh. As you mentioned, 3 years. We're still talking about it. We're still wary about surges, wary about overstrain our health system. So how do you see 2023 in this realm? And this, by the way, I haven't mentioned that the other viruses are coming back as well and have come back with a vengeance as we expected. So what do you expect for 2023?
Cesar, I said this in 2020. I said this in 2021. I think I'll say it again. I'm cautiously optimistic. I don't think we can give up hope. And again, for me, you can look at a glass as half empty as half full. From the half full approach is, okay, we are still in the pandemic and it's still going on. That is true. But look at the half full approach. Within a record number of time, we were able to unite not just as infectious disease as microbiologists, but as a global community. And uh, like we have battled the pandemic, mortalities have come down, infection rates have come down. We have developed vaccines, we have developed treatments, and regardless of the virus trying to mutate and have more variants, we have always kept pace with it, and we are able to overcome it. And I think that is a good thing. And another silver lining on this black cloud is how much we have learned. I think the best approach that COVID has taught us for any other infectious disease is adaptive platform trials. You can study multiple agents at multiple doses, have interactions, and you can evolve. And that applies to Staph aureus, that applies to gram negatives. COVID-19 taught us that, right? I think doing a frequentist approach in a regular randomized controlled trial, you'll never find answers that quickly and that effectively. So, and even in terms of like how do you organize your healthcare resources to respond and collaborate. So not only is the pandemic much more manageable, I think it has taught us life lessons. My biggest fear is the pandemic is going to go down at some point, maybe not in 6 months, in a year, and we will start going back to our old ways rather than not learning from what the pandemic has taught and dealing with other infectious diseases in a similar way we dealt with in COVID-19.
Very wise words. And with that, I'm going to wish you all the best for next year. I, like you, remain optimistic that we are going to pull through this. We're going to have our surges. We need to learn how to live with this virus and other viruses. And hopefully, we won't have any other surprises, but you never know. The most important thing, as you mentioned, has been to learn and how to organize and work together to maintain this level of knowledge and evidence and do things based on science. I want to thank you for your time. You're smashing hot. And I want to also thank the Journal of Clinical Microbiology podcast, the Editors in Conversation sister podcast, for inspiring us to wear silly hats and be festive. That was a challenge well taken. Thank you very much, Ellie and Alex. And thank you, Adarsh, for that. Happy holidays to everybody. This is Cesar Arias, Editor-in-Chief of AAC, signing off.